Good morning, everybody, and welcome to today's fireside chat with Peter Kapitein, a patient advocate and member of the Innovative Health Initiative's Science and Innovation Panel, amongst many other things. My name is Hugh Laverty, and I'm the Head of Scientific Operations here at IHI. And I'll accompany you over the next 40 or 45 minutes while we learn about Peter's career and his work as a patient advocate. I'm very fortunate because I'm a bit in control, so I get to ask lots and lots of questions. But we encourage you, if you've got some burning questions for Peter, to use the chat function and to actually write in your questions. And we'll allow some time at the end to try to ask Peter some of your questions directly. And with that, I want to welcome Peter. So good morning, Peter. How are you today?
I'm fine, Hugh. Thank you for asking. How about yourself?
Yeah, no, I'm great. And I'm really pleased that you've taken the time to join us this morning. Maybe before we get into your work about patient advocacy, you could tell us a few words about yourself and currently what roles you've got, what are you involved in at the moment?
Yes. Well, Peter Kapitein, I'm a patient advocate. I founded an organization, patient advocacy organization, Inspire to Live in 2010, together with a couple of other people. And the reason for that goes back to January 7th, 2005. I was diagnosed with a lymphoma, a pretty normal lymphoma in my part of the world, so to say. But in my situation, I had several relapses in 2006, 7, and 8. And there was at the end only one option left, which was an unrelated allogeneic stem cell transplantation. The preparation for that with 3 times in March, April, and May 2008, 1 week of high-dose chemotherapy failed. So I was really running out of options, and my physician and I decided to plan an autologous stem cell transplantation with, again, 10 days of high-dose chemotherapy before the allogeneic stem cell transplantation on September the 3rd, 2008. Well, that appears to be a success. As you can see, I survived, but I not only survived from the start, from the beginning of my new life, so to say. It almost feels like being reborn after an allogeneic stem cell transplantations with stem cells of another human being. I had pretty close to 100% quality of life ever since. You could say as a kind of giving back for all the good treatments, nurses, physicians, but also family and friends. I thought, well, let me use my talent, maybe my only talent, to organize and set up things, organizations, to give back what I got. And that appears to be Inspire to Live, a global patient advocacy organization with representations in over 50 countries with more than 100 professional volunteers as advocates.
So, I mean, you've been through what many of us would consider a pretty scary process with a lot of doubt, and undoubtedly you felt quite scared at times. I mean, and this, as you've said, led you into thinking about what you could give back. How did you go about establishing Inspire to Live, and becoming the patient advocate that you are today?
Yeah, well, I think that's a beautiful story. I simply asked my physician who came up with these stem cell transplantations, and it appears to be 2 lead investigators, one in the United States, at that moment MIT, and one in the Netherlands. And I thought, well, he's probably not alive anymore, but he was. It was November the 4th, 2008, that for the first time I met with him. His name is Dick van Beckham, director of the Radiobiological Center in the Netherlands. And he designed the protocols for the stem cell transplantation. He was a scientist, so he was not, of course, allowed to treat patients, but he cooperated with a physician. And I worked with him until his death on July 17, 2015. He was 90 years old, almost 90 years old. And he learned me a lot. He learned me science. I'm not a scientist by education. I'm a librarian by education, as you can see in my background. But he learned me basically how scientists work. And one of the most fundamental things is start with knowing what's going on. The second thing is keep your eyes wide open and your ears wide open, but stay focused, be very persistent, and you don't have to be liked by everyone when you do your work. And that's basically the fundament of the organization Inspire to Live. Our fundament is science. Know what's going on, cooperate a lot, and then act. Important part of our organization is really knowing what's going on, but research is necessary, and what we call evidence is necessary, but it's not enough. You have to act, and you have to make it available, and you have to make it available for patients.
Yeah. And I mean, you've touched upon several different things there about know what's going on, pay attention, stay focused. But in your opinion, what's really important in your job as a patient advocate? What's the key thing?
Basically, I always have what I call the end in mind. And the end in mind is quality of life for patients and their loved ones. So all the work that we do in healthcare should contribute to that. So data is important, research is important, making treatments is important, but the end goal is quality of life for patients and their loved ones. So my quote would be, it's not about the data, it's not about the research, it's not about the treatments, it's about quality of life for patients. And for that, you need data, you need research, and you need treatments. And for that, you need the cooperation of all the stakeholders in healthcare. That's exactly why in our organization, we have patient advocates, researchers, clinicians, people working in industry, people who know about regulations. A wonderful guy from he was fired by Trump from the FDA, but he is now part of our organization. He knows about regulation. We're very glad with him because I know nothing about regulation, and I think that should stay that way. But all stakeholders need to be in place for the end goal, quality of life.
And I think, as you've mentioned, your experience with your own cancer required resilience. It required undoubtedly persistence as well, and hope, because you've mentioned that there were periods when things weren't going to plan. And I suppose these are qualities that you need to bring into your patient advocacy as well, not just as a patient, but has that been your experience?
Oh, yes, yes. Being a patient advocate means dealing with disappointments. For that, you need persistence to get over it, and don't stick too long in your disappointments, because it's wasted energy. It helps enormously to work with fellow patients and patient advocates. Within our organization, we lose almost every year we lose 1 or 2 patient advocates. and they always make us stronger. So and always motivate us to never ever quit, because an important part of our work is to show the other stakeholders that we're dealing with our problems. So taking care of good quality of life and overcome a lot of barriers means we're dealing with our problem. When I talk to an audience, I always say, it's my problem. I need you for helping. I need your help for solving that problem, for coming up with better research or better treatments, but it's my problem. So that means that we, patients and patient advocates, should take the initiative, or at least knock on the door of scientists or physicians or industry or regulators. Hey, you're dealing with my problem. That's why we always say, when it deals with access to medicines, for example, patients should be in the committee that says yes or no to a new medicines. Quite some discussion are about risks for patients. How can you talk about risks for patients without patients? So if about it, not without us.
Yes.
How can you come up with good research if you don't know what are the real problems of patients? Let me give an example. Nobody does research in pain in pancreatic cancer patients. But and by the way, almost nobody does research in pancreatic cancer at this moment, and we should do a lot more because it becomes the most lethal form of cancer within 10 years. But if we take away the pain in pancreatic cancer patients, we give these patients 6 to 12 months more with a good quality of life. Now we only give them morphine, which takes away the pain, but it also decreases the quality of life of patients. By doing research on other pain relief medicines, we help these patients much more than simply doing research in the way we did so far, which I call phase 1, phase 2, phase 3. Oh, we fail again with a new drug. So at least continue doing research on how to cure, or at least how to extend the life of pancreatic cancer patients, but also do research. Well, that is something that only comes up when you work with patients, because they show you the pain and they show you the decreasing of quality of life with morphine.
Yeah.
So I think the cooperation set up by patients with all other stakeholders in healthcare, research, clinicians, industry. I think the cooperation is the key word in being a good, setting up cooperation is the key word in being a good patient advocate. And then, of course, you need to be very persistent, you need to be eloquent, you need to have guts, because like I said before, you will not always be liked by everyone. But in the end, let me give a beautiful example of patient advocacy, which are the ACT UP advocates from the AIDS movement. Peter Staley, one of the founders of ACT UP, was extremely critical in the end of the 80s and beginning of the 90s, former century, to Tony Fauci.
Yeah.
Fauci was, in those years, he only retired a year ago, the head of NIH virology. Extremely critical. And if you saw discussions between those two men, you would probably think they would hate each other very much. They're still the best friends. Yeah, because both Peter Staley, both Tony Fauci knew what they had to do. Bring good treatments for patients with AIDS. And for that, you need to be very critical to each other.
Yes. I mean, I think it's a really good point, because, I mean, what links them is their willingness to talk and communicate and to meet and to discuss.
Yeah.
And I mean, you've mentioned going back to the 80s with AIDS, and you've been involved in patient advocacy since, the early 2000s. How have you seen patient advocacy evolve in that period? Because from my perspective, I've seen a big change in the way that patient engagement is now occurring compared to even 10 years ago. But from your perspective, what have you observed?
Yeah. Well, we started indeed in the early 2000s when our organization in the Netherlands introduced patient advocacy. We were in those years, 2008, 9, 10, we were accused of being very aggressive, which was not our intention.
I can't believe it of you, Peter.
No, but it was new, and people were not used to see patients stand up and tell them, hey, we want to do it differently, or hey, we want attention for this problem. Our organization started working on cancer rehabilitation. In 2007, 2008, we started working with scientists and physicians to set up how to rehabilitate cancer patients. The next step we took was a chair at the Free University in Amsterdam for living with cancer patients, which was on the psychology department of the Free University. Pay attention to mental health for patients. The third step we took was nutrition and cancer. So basically physical aspects, mental aspects, and the food, the nutrition aspects. And that was completely new. But if you look for the right people, because there are always people, even if a lot of people think you're aggressive or you should stick to your own topic, there are always people who are curious and think, hey, maybe these people are right. Let's go into conversation with them. And from the start, I felt with the people that I worked with completely equal. That was not for everyone, but the evolution was indeed that if you know what you're talking about, and that's really important, you have to know what you're talking about. So being a patient advocate is going on stage, but you can only go on stage when you know what you're talking about. And that means a lot of homework, a lot of reading, a lot of writing, a lot of discussions. Be prepared. And if you're well prepared, and then you will see that people change their opinion about advocacy and they start working with. Because in the end, and that's my strong belief, people want to contribute. In the end, whether you're a scientist, whether you're a physician, whether you work in industry or as a regulator, you want to contribute. You don't want to work for 40 or 50 years and retire and simply say, well, the only result, it's a quote of one of our physicians in the Netherlands working on pancreatic cancer. My result after 50 years of work is that we are now able to cure a mouse with pancreatic cancer. No, you want to do more. You want to contribute to patients, but contributing to patients means that you also contribute to society. And that's my definition of doing good. But you're doing good when you contribute to society. And being good prepared, being eloquent, doing a lot of work, cooperate in a very critical, not aggressive, but in a very critical way with the other stakeholders will show that patient advocacy becomes important, and patient advocates will mostly be respected by all stakeholders in healthcare.
I always liked when I first got to know you, you always described yourself as an activist. And I think that's a very, there's a lot of energy in that word, activism, action. doing things, and
Yeah.
that always came across.
Well,
And
I learned that activism from an AIDS researcher clinician. His name is Joep Lange, and his quote was, "Inaction kills."
yes,
Yeah, so if you don't act, people are dying. So
yes,
you have to prevent them from dying if you're able to. And basically, that's the motivation that most patient advocates have. We're not able to cure every cancer patient. Yeah, but in the end, it is about doing what you can do.
yes,
And if you have done everything that is possible to do to help a patient with cancer and for other diseases, it's exactly the same. If you have done everything you could, well, at least you can live with the thought and the feeling when this person passes away.
yes.
Yeah. So,
Right.
and it's a quote from a wonderful professor I've learned, I know from Rwanda. Um, I'm not ashamed of not doing everything, but at least I do something. You
Yeah.
see, and in this quote from Christian Nitisimira is a lot of wisdom. I think we're here in healthcare in one of the most important, I think the most important business that you can think of. We're dealing with life and quality of life, which is something different from a lot of other industries.
Yes. Very true. And could I maybe just been a bit selfish now? I work at IHI, and this is where I got to know you. But why did you get involved in a program like the Innovative Health Initiative?
Yeah. Well, the start was simply by coincidence. Someone from Bulgaria, Dimitar Georgiev, said, "Peter, I think this is something for you." And if he hadn't mentioned it, I would probably not seen it. But I read through the documents he sent me or the link on the website of IHI. And I immediately thought, yes, this is something for me. Why? IHI is about science. IHI is about good science, and IHI has a big impact because it's an organization with big funds. And then I saw all the participants, and I think, well, this is a representation of the stakeholders in healthcare, which is necessary, with one critical remark, and that is, I'm the only patient advocate in the science and innovation panel, and I think we should do something about that. But it's a good representation. It has a good funding of good research, and the cooperation between the EU money and industry, I think that works. I believe in public-private partnerships. So reading through that, I thought, well, this is a good organization for me. And well, I've now visited it for, I think, 4 years.
Yeah.
From the first moment on, I felt as completely respected and equal. And sometimes I think I think we should have more focus on the outcome for patients. So quality of life of patients and their loved ones, like I said before, is very important. If you allow me to continue on what can be done on IHI, I think we should have focus more on ethnic diversity. This is very, very important. Whether it is breast cancer in women or prostate cancer in men, there is a huge difference between black men, black women, and white men and women, and that should be emphasized more. I think that is a very important thing that we can improve. I know that IHI is moving in that direction. So, but as a good patient advocate, you have to be impatient. So we need to speed up that process. That's very important. But I think every meeting I have, whether it's the the joining of the SIP in person or virtual, or the open door sessions set up by Anna Chiatti, the chairwoman of the SIP. I always like to be involved and always like to contribute.
Yes. No, and I can tell everybody who's listening in that you're very active. You live up to your name as a patient activist. And you touched upon a little bit, one or two aspects that IHI could focus on maybe more. Are there specific things apart from adding more patients? Do you think that could be done differently that would actually drive more impact from a program like IHI?
Well, my role as an advocate is I know a lot about oncology. So and there are a lot of oncology topics, so that's okay. But there are also quite some topics on mental health, and I feel I'm a little uncomfortable when it comes to mental health because I know something about it, but not that much as should be. So an advocate with an expertise on psychiatry or at least mental health, that would help enormously. And I think the patient pool could play a more active role in the discussions of SIP, setting out short surveys in the patient pool about the ideas that are brought up and are being discussed within SIP. For the audience, if the work of the SIP is not to review proposals, but to talk about what are good ideas for call for proposals. So the input of the patient pool could be stronger in the discussions within the SIP.
Yeah, I mean, this is a really good point because this is something we're trying to define because the SIP has a limited number of people. There's a limited number of seats, and we've got quite a large stakeholder. So we have, as you said, one SIP member who's a patient representative. And then we have the patient pool, and we're trying to explore how best to use that, because we want to actually tap into and make best use of patient experience, of the lived experience that you all have. I'd just like to remind everybody that there's the opportunity to ask any questions you might have. So just add them into the chat, and we'll bring them up with Peter. So if you get bored of my train of thought, it's very good to bring on board some of your ideas and your thoughts, and we can share them with Peter. In the context of your experience, you've been very active in the field. You've set up Inspire to Live. You're working on a global level, not just even a European level. How do you actually see patient advocacy evolving, or developing over these next few years? What would be the next important steps from your perspective?
I think what we advocates can do better is look after the position of the other stakeholders. So we know very well what our needs are, what our interests are. I gave the example of pain in pancreatic cancer patients, but there are dozens of examples, hundreds. But if you really want to achieve your goal, and that counts for every stakeholder, but if you really want to achieve your goal, you have to know why other stakeholders are in it. Let me give an example. In my country, the Netherlands, it takes more than 500 days before a medicine is prescribed by the physician for her patients. The reason for that are several, but a very important one is pricing of medicines. Now, it's quite simple what the interest of patients are. The patients want the medicines as soon as possible because with these medicines, they will live a longer life or might even be cured. So that interest is quite simple. But if you, as a patient advocate, only look at that aspect and knock on the door or government or industry or whoever, that door will not open very quickly. So you first have to understand the interest of the other part. Well, the interest of industry is also pretty simple. When it takes 500 days, it means simply that for 500 days they have no revenue and profit, which is important for industry, of course. And yes, I know that a lot of people in industry say, well, we need these revenue and profit for improving the quality of life of patients, and I believe that. But let me be the advocate for patients and not industry. So industry interest is quite simple, but you have to understand them, which means talk to them, work with them. And a lot of patients dislike industry, and they are wrong. And by the way, I think regulation within industry that prevents them from working with patients is wrong. So we should do something about that as well. But then comes the third party. Let's call the third party society. The society, the government, who say, hey, but we do not want to pay too much for our medicines. That's a difficult one. That's a difficult one. But I think patient advocacy can work on that and improve the outcome of patient advocacy by really knowing what's behind that. We don't want to pay too much. That's a price, that's cost effectiveness, that's reimbursement. There are several aspects that need to be known before you can step into the discussion with government, with the representation of government, which are several institutions in the Netherlands. So I think what patient advocacy can do better and should do better to improve the outcome of their work is knowing why industry, why investors, why government is in this, what are the reasons for that, and by understanding the reason will not mean that you have to be working for industry, but you have to be aware that working for patients as a patient advocate might even mean that you will improve the outcome from the other stakeholders. So I think, to make it a short story, what patient advocacy should do is look better after the possibility of a win-win-win situation, and there are always win-win-win situations.
Thanks, Peter. I've got a question now coming in from the audience, so thank you. The question is, patient involvement has become a standard request in European grants, but the how to achieve this often remains unclear. Can you, from your experience, give some concrete examples of how to involve patient advocacy in clinical trials and large projects?
Yeah, I think first thing to say is that is a very good thing, that we need to be involved. By the way, we need only to be involved in being part of the initiative, but also being paid for that. I think if it's work, and it is work, because you cannot be involved when you're not working in it. It's not simply by reading through a document and tick in the box. It's working with it. So I think it's a good thing. We are now in our organization now is into several proposals. Two here in the Netherlands, one international, and we are asked to work in these proposals to make the proposal as good as possible. One is a cancer grant challenge, for dark proteomes. We hope to be granted. We are now shortlisted, 4 of them in the last 4. But our patient advocate that will be part of that initiative, when granted, will be an equal person in that consortium paid for that. So I think it's a good evolution. It's very good that it happens, but it demands for patients who know what they are talking about, and you're only taken serious when you know what you're talking about, and it starts with that.
Yeah.
It starts with that.
Okay. There's another question that's come in, which I think it's more for the office, and it's, are there currently any patient expert slots on the SIP open for appointment? The short answer is no, because the SIP is one of our statutory bodies that was established whenever IHI was established. So it's part of an ongoing discussion about how we get more patient representation into IHI. And we can expect that if there is another IHI2, a follow-on program, that these slots may then become open. Of course, it's all dependent on what type of advisory bodies the commission and the members decide they want to put in place. I mean, time is flying, and unfortunately, we don't have enough time. I could spend hours and hours chatting with you, Peter, and as we often do at meetings and
Yes.
at social events. So I'll ask this, not the last question, but if someone is considering becoming a patient advocate, or they've gone through an experience, as you described, with your own cancer, and they're really seriously considering it. What advice would you give them if they haven't got involved before?
Start talking with patients a lot about their needs. I think that's very, very important. Start talking with researchers. And it's easy to get an appointment with a researcher. All researchers are kind people and want to talk with you. But you have to be aware that you will get all the appointments you want, but your second appointment you have to work for. So again, I repeat myself, you have to know what you're talking about. But start talking a lot with researchers, start talking a lot with doctors, because there is a difference between a researcher working on, of course, on research, but the research of today is of no use for the patient of today. So there is a huge difference, and you become aware of the innovation of the clinical practice, which is way too slow. In one of the first meetings I had with Sir David Lane, he said, "We do not execute what we already know." And I think that's a very important quote. And you cannot immediately do the next day execute what you began to know in the laboratory. But I think the slow path between research and innovation of the clinical practice is something you have to become aware of as a patient advocate, because that is basically what you want to do, to speed up that process. So talk a lot with patients about their need of researchers. What are you working on? Discuss with them if that is really the essence of what should be done, what should be done, and talk with physicians. And then the hard part, talk with regulators. Regulators are people who can be very annoying for patients, but they're very necessary. Within our SIP, Ralph Harold is a wonderful example of a contributing regulator.
Mhm.
So basically, it starts with meeting with a lot of people, discussing with a lot of people, so that you're well prepared. And then after a couple of years, because that takes years, ask yourself the question, do I really want this? Because your path as a patient advocate will be spread with disappointments.
Mhm.
And that is something that a lot of people cannot deal with. But it's part of your profession as a patient advocate. I call it a profession.
Yeah.
There's a beautiful quote of Peter Staley in around 1990 as an AIDS activist. That was the moment I decided to become a full-time patient advocate. It's not something that you can do for 1 or 2 hours a week. No, 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 no. It's something. It's a profession, which doesn't mean it needs to be 40 or 50 hours a week, but it's not something you can do in a couple of hours a week.
Yeah.
So ask yourself the question: am I prepared to do this?
And I suppose it comes back to that aspect of resilience, persistence,
Yes,
knocking
yes,
on the door continually.
yeah. But it is. There are, of course, nights that I go to sleep and I go to sleep with the thought, well, this was my last day as a patient advocate. But then I wake up the next morning and I think of Nicole,
Yeah.
Linda, people I have known who have passed away. And I simply say to myself, looking in the mirror, hey, come on, you're not going to tell the sister of Nicole, or you're not going to tell the husband of Linda that you're tired and that you're so disappointed and that you're so sad that you have to quit. Come on,
Yeah.
get yourself together and step into this job again. And then there are beautiful moments. One of the most beautiful moments, and I almost never can talk about it without becoming emotional, is I was called by a woman I did not know, and she said my father had an allogenic stem cell transplantation, and that failed. Well, you're pretty much out of options when your allogenic stem cell transplantation with a follicular lymphoma, like I have, failed. But she said, "Can you do something? Do you have an idea?" And I said, "Well, I don't know exactly, but what I can do is bring you into contact with my physician, who is one of the lead investigators in CAR-T. And well, at least that's something I can do." So I connected her with Professor Maria C. Kersten, and well, that was it. And 1 year later, I got a phone call from that woman, and she said, "You won't remember me, but I am the woman that called you about my father." And I said, "Oh, yeah, 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 yeah. Your father failed on an allogenic stem cell transplantation. And I connected you with Maria J. Kersten, which is also my physician." And she said, "Yes, my father has been cured by the CAR-T treatment." Well,
Wonderful.
that gives energy. That gives
Yes.
energy. Yeah. So it's many years ago, I think 6, 7 years ago. That gives energy, and that shows the capacity of patients and patient advocacy, but it also shows how research, how physicians, but also how industry, how regulators contribute to this beautiful new treatment CAR-T.
Yeah.
So that brings energy and that gives persistence and that makes sure that I will never ever quit.
But that's very good news. It's a lovely story as well. We're into the last minute, and I have an impossible question for you. So it's impossible to keep because it's going to be quite difficult to keep it very short. So, who has inspired you?
Mm. Well, it starts with all the patients that I've lived with that passed away, whether it's in the hospital or outside the hospital. And I can many examples, but that's what it started. And then like I said, it is our problem. It is my problem. I'm a patient. I have a follicular lymphoma, or other patients have different forms of cancer. But it starts with, this is my problem. Who inspired me? I want to mention two people. One is Dick van Beckham, the one who invented, so to say, designed the protocols for the stem cell transplantation. I learned a lot. Another one is Stephen Friend. Stephen Friend, who is from the US, Seattle. He was basically together with other, but he walked on the streets in Boston when he was working at the Whitehead Institute with Bob Weinberg. He walked on the street and he saw a father and his son both missing their right eye. And he asked the father, what happened? What's going on? And the father said, well, we both have the retinoblastoma. It was 1982, Boston. And he walked into the office of Weinberg, Bob Weinberg. He said, Bob, I'm now going to prove that cancer is a genetic disease. We all knew, but there was no scientific proof. That was when he started working. And Bob Weinberg said, but Stephen, you do not know enough about that. And Stephen said, of course I do not know enough about it, but in a couple of years I will. 1987, there was a famous Nature article published with Weinberg, Friend, also Rene Bernards, about this situation, this topic. So, and I work a lot. Probably this evening I also have a meeting with Stephen. The inspiration that comes out of it is enormous. So my two names are Dick van Beckham and Stephen Friend. But I will never forget my own physician, Marie-José Kersten, who saved my life.
Well, thank you, Peter. It's a real shame, but with that, it's time to draw our fireside chat to a close. Before we finish, I just want to give a few thanks. So to Nasima and Catherine, who you won't have seen, but they're from our communication team.
Yeah.
And they've been hard at work on the planning and the logistics in the background. So thank you to them. I want to thank those of you that joined us today, because it's been a really inspiring 45 minutes. And I hope you've enjoyed hearing about Peter's experiences as much as I have. And finally, to Peter yourself, a huge thank you from the IHI office and from myself. It's been wonderful to hear about your career, your experience, and your inspiring words. And I'm sure a lot of people will be inspired by you today. And I can only wish you every success in your future endeavors. So that was IHI's Fireside Chat with Peter Kapitein. Thank you again to all of you who joined us today. And with that, I wish you a very good day.
Thank you.